I really am humbled as Professor Hogg comes to the podium to introduce him. I think you heard earlier about the Gairdner Foundation, and it is in the Nobel Prize winning category. It's really the main event today to hear Jim talk, to present his research. It's a real pleasure to have him as a colleague. So Jim, thank you for allowing us all to be here and causing us all to be here by your great work. So we'll ask Professor Hogg to address the topic Pathobiology of COPD.
Thanks very much, Mark, for those very generous remarks. And I'd like to add my thanks to all of the people who've traveled so far and gone to the trouble to come to Vancouver for this. I'm truly humbled to have you all with me on this day. And I'm very glad to be able to move forward and tell you something about our new research. Now, I'm going to talk about the pathobiology of COPD, and that's my name, but I really want to get on to this very important piece of work that was done, as everybody, most people involved in COPD will know, by Fletcher and colleagues back in the mid part of this century. And it shows here very clearly in a population of workers from London that they followed for a total of 6 years and calculated statistically these grams. And superimposed in this, something that came in much later than theirs, is the gold categories of COPD severity. Now, you can see that everyone here in this population declined over their lung function. This is expressed as 100% of their FEV1 at age 25. When you're at the best you're going to be, everything's downhill from there. And people here who don't smoke, this is their rate of decline. If you do smoke, the majority of people show this rate of decline. And their data suggested that if they stopped smoking, you recovered, not completely back to the control, but you did tend to recover. But the most intriguing group was this susceptible minority of people, as they described it, who had this very rapid decline in lung function. And many of these people had smoked no more than the people in this population that didn't decline very much. Now, we now know from research done by a number of people that you can get onto this curve for things that happen to you before you're 25, particularly premature birth and childhood infections that can cause, especially if they're before the age of 2 years, can put you in a situation where you never get to your best and you end up over in this curve. But by far and away, the biggest part of this is associated with this rapid decline in this small group is the inhalation of toxic particles and gases, of which the tobacco smoke is clearly the most prevalent, but not the only cause of this decline. Other inhalation of particles like exhaust from automobiles and other things, and different kinds of exposure can put you on this task. Now, here's a perfectly normal human bronchial tree. And what goes wrong in COPD is one of the major things is chronic bronchitis, which is a clinically defined entity based on chronic cough and sputum production, and obstruction to airflow, which is primarily located in the small airways. The small airways normally account for about 20% of the total airway resistance. And because they're arranged in parallel, as you remember from your high school physics about thinking about resistors arranged in series and in parallel, when they're arranged in parallel, you can knock out half of them and you'll only double the resistance. So if you double the resistance of something that was very high in the first place, it doesn't have a big effect on total resistance to airflow. And that's an important concept as we move forward. And then there's the association that we have with the destruction of the gas exchanging surface by emphysema. Now, my talk is going to be largely concentrated on these last two entities, the small airway obstruction and the emphysematous destruction of the lung. Now, here's a perfectly normal lung, the same lung that you saw previously with a close-up view. And if you shine a light through the lung and take a picture from the pleural surface, you can see the outline of this lobular septa, and that's a lung lobule. And it contains many terminal bronchioles, as you can see here, breaking into respiratory bronchioles, which you can barely see at this magnification. Now, this is a new technique, a relatively new technique applying to the lung, is micro-CT, which allows you to see this area much more clearly. You can see a terminal bronchiole here breaking into a respiratory bronchiole where the alveoli first appear. And those terminal bronchioles are clearly pointed out in these arrows. Now, there's the normal lung that we looked at previously, and this is what happens to a lung that's affected by central lobular emphysema. This is a person who actually came to autopsy, was not known to have respiratory disease, but in the postmortem findings, there was this beautiful example of central lobular emphysema, and you can see this hanging here very beautifully, almost like the balls hanging on a Christmas tree. Now, if you look at that at higher magnification, this is a micro-CT, this is a picture taken by a postdoctoral fellow, Dragish Vasilescu, recently in our laboratory. And you can see the terminal bronchiole breaking into a respiratory bronchiole. And you can see this example of the central lobular emphysema here. Here's the lobular septa out here, and you can see this example of central lobular emphysema. And then the very periphery of the lobule here, you can see the preservation of the lung tissue. If you take this example, it's the panlobular form of emphysema, and you can see here the dilation of the alveoli, and it involves the entire lobule sort of evenly and the lobule next to it. And here is the next one, which is the paraseptal form of emphysema, which is seen very clearly here affecting the periphery of the lobule next to the lobular septa, where the tissue close up to the terminal bronchioles is well preserved. Now, these are well-described phenotypes of COPD, initially described entirely by pathologists in the great old days when pathologists controlled everything. But the introduction of the CT scan has made it possible to diagnose these phenotypes of COPD very accurately in the normal population, or in the population. And this is very, very recent results, as yet unpublished, from the CANCOLD study, where two radiologists from this hospital, Dr. Leipzig and Dr. Cameron Haig, independently looked at almost 700 CT scans without knowing anything about the lung function. And talking to them while they were doing this, they sort of told me that they feared that they were doing all this work and it might turn out as a lump of coal, that it wouldn't be worth anything. But I think they've made an enormous contribution, because what they've shown here, when you plot their data, here is the various types of color code for the various types of emphysema that we've just talked about. And this is, the color code goes from mild central lobular to moderate central lobular to severe central lobular to very severe. And you can see from this color code that the central lobular is the dominant phenotype of COPD. Then you also have the paraseptal emphysema and panlobular emphysema here, which panlobular, this is a population-based study now of 9 Canadian cities. So when you look in a population-based studies, which is not enriched for people with COPD, panlobular seems to be relatively rare. If you look in the COPD gene study, for example, where it's enriched for people with COPD, panlobular emphysema is much more common than they found it in this study. But I think the most interesting thing is they found this emphysema here in the very early stages where these people have no evidence of COPD based on measurements of lung function, and that it progressively increases as the disease gets more severe. Now, I'm going to tell you about some of the methodology and the things that we've done to try and look at this relationship between the small airways obstruction and the emphysematous destruction. And the approach we've taken is largely based on lungs that are donated to us by patients who are having lung transplants. So after they're accepted into the transplant program, and they're settled down in there. They're approached by a person who doesn't have anything to do with either their health care or with the research, and they're asked to donate their lungs. And when they get their lung transplant, and a very large percentage of them do. Now, the first thing we do is freeze the lung, inflate it and freeze it. That's an inflated frozen lung. That is very high tech. We take a bandsaw and cut it into slices. And those slices, those slices are shown here. And you can appreciate the emphysema that is present on this lung. And you can also appreciate that some parts of it look nearly normal. Now, the next thing we do is to take samples of the lung, and we use those samples for different things. This one we do micro-CT on, and I'll tell you a little bit about what we found with the micro-CT. The next one we do quantitative histology on, and the next one we do a microbiome analysis on, and the next one we do a host gene expression. Now, I'm going to talk mainly about the micro-CT and the quantitative histology and the host gene expression profiling. And that host gene expression profiling has been done entirely by Dr. Avi Spira and his group at the Boston University. And Avi will be speaking later this afternoon about some of the more interesting and recent work we've done on this. Now, this is an example of micro-CT. The advantage of micro-CT, it allows you to go through one of those cores of tissue very quickly in 4 micrometer steps, something that would have cost, you could do with histology, but it would take about 2 times the money as micro-CT and about 4 times the time. Now, here is a terminal bronchiole, and here is something that you can't really recognize. If you got that in histology, you're stuck with it. There's not much you can do. But the micro-CT allows you to adjust that into the XY plane so you can perfectly see this relationship between the terminal bronchiole and the respiratory bronchiole. And you can use the same software to turn that into the Z plane so you can follow the airway here and measure its dimensions. And that's a huge advantage. Now, if you do that on a number of control lungs, and the control lungs are donor lungs that aren't used for one reason or another for a transplant, and there's the frequency distribution of the measurement of LM, which you can make at 20 different levels in those cores, and an amount of work which should be sort of impossible to contemplate doing that from histology. And this arrow shows the 95% confidence limits of the control lungs. Now, these 2 curves show the panlobular emphysema and central emphysema dominant COPD in the lungs from people with Gold 4 disease. But these are the areas of their lung that are normal. Their LMs are normal, and we initially thought these would serve as perfect controls for the abnormal regions of their lung. But what we found as we went forward with the micro-CT is that here, while we were still inside the 95% confidence limits for the normal in terms of their emphysema, there had already been a sharp reduction in the number of terminal bronchioles in those lungs. So, and it wasn't quite as clear in the panlobular, although when we look between the 95% confidence limits and 100 micrometers, which is the lowest level that can be picked up on the regular CT scan, you can see that in both cases there was this very sharp reduction, very, very sharp reduction in terminal bronchioles, and that persisted into the more diseased areas of the lung. So the take-home message from this part of the work is that the terminal bronchioles are lost before emphysema becomes visible on the CT scan, so that by the time you've seen emphysema on the CT scan, you've already lost a very large number of airways. Now, if you take that back to what we looked at previously, our working hypothesis, and it is a hypothesis, that will be sorted out as the CAN-COLD study goes forward with time in a longitudinal basis, but our hypothesis is that in these people that don't have COPD, that already have emphysema, they will have already lost a large number of their terminal bronchioles. Now, the question that I'd sort of ask you to think about is, what if you started to lose your terminal bronchioles at a rate of about 1,000 a year? I think most of us, if you were told that, would be worried about it. You'd think you should do something. But let me say, if you started at age 35, that would take you 20 years to lose half of your terminal bronchioles, because the average, you start out with about 40,000 terminal bronchioles in 2 lungs. If you lost half of your terminal bronchioles, you would double your peripheral airway resistance, which, because it was low in the first place, would have relatively little effect on your airway function. So that the hypothesis is that you have really started to lose your airways probably on a regular basis when you're one of those rapid decliners. And you're losing them at a pretty fast rate before most of the treatment clinical trials have even started. For example, if we go back to the Fletcher diagram that we showed initially, the appearance of emphysema prior to the onset of COPD may identify, that's the hypothesis, this susceptible minority, because they've already lost their terminal bronchiole, and there's evidence, really beginnings of evidence, with a new technique that's been worked out by Galben and Associates that was published in Nature Medicine just at the end of earlier this year, that you do lose what they call the functional small airway disease. You develop that long before you develop any emphysema in your lung, as you do inspiratory and expiratory scans longitudinally on people. And of course, we've got inspiratory and expiratory scans on the CAN-COLD group, and the analysis is already underway, and we begin to get answers to these questions. But I think that the most important thing is that the trials designed to treat COPD that have all failed to reach their primary endpoint of interfering with interfering with the rapid decline in lung function and stopping that rapid decline, that may happen because they've all started too late when most of their airways are already gone. But we'll see going forward if that is really the case or not. Now, let's move on to comparing the micro-CT to the histology in those extra cores. Now, the technique that we use is the math. The people who did the thinking about this are geologists. Now, when a geologist takes a rock and wants to find out how much gold that's in it, the first thing they do is volume the rock, and then they break it into little pieces, and they get a random sample, and they calculate the area fraction of the ore they're interested in the area that they look at in those representative samples. Then they multiply that area fraction by the total volume, and they get the volume of the ore that's in that rock, and they know whether it's worth mining or not. We use exactly the same technique based on micro-CT and histology. The rock that we use is the whole lung volume, and we separate into its tissue and airspace compartments using the CT scan of the specimen that we take before we cut it up. And then these cores of tissue are there, as we said. We can place them perfectly in there, and we can take actually on the same core of tissue now, that we can take that tissue and look at the histology. Now, if we point count, you can ask the computer in that area to say how much of the area is tissue and how much of the area is air. And then you can circle around the airways, and you can say what fraction of the tissue is actually taken up by the bronchioles. So then you can compute the volume of bronchiolar tissue in your sample. And then you can go to the next level, which is histology, and you can use special stains of serial sections to identify the volume fractions of all these cell types and the various collagen types. And you can move forward and then summarize this. Here is, along this axis, we have the controls and the emphysema-free and the mild and moderate emphysema. And you can see the total volume of tissue here. It increases a little bit, presumably as the airways thicken. And then as you lose airways, the volume fraction of the tissue that's bronchiolar tissue is small. Now you can see as you look at this color code, this is inflammatory cells, all of the inflammatory cells. Here, this is the elastin, and this is for the bronchiolar, whoops, I went too fast. This is for the bronchiolar tissue. I don't know where the label has gone, but it's gone someplace. But you can see this is the inflammation. That's the elastin, which decreases. This is the amount of collagen 1. This is the amount of collagen 3. This is the total collagen, and this is other tissue. So you can see the remodeling of the tissues that have taken place as you go along the emphysematous destruction. Now, if you look at that area of the inflammatory cells and compute now the polymorphonuclear cells, again going with the level of destruction, you can see they tend to go down. The macrophages tend to go up. The CD4 cells tend to go up. The CD8 cells go up, but they're not quite statistically significant. And the B cells are smaller numbers, and they increase in their statistical significance. So this is expressed as a volume fraction, and then you can look at these cells and see how they relate to emphysema. And when you look at what is the important thing, this is what's called a random forest regression analysis for the prediction of the LM, which is the measurement we make of emphysema from the histology, and the various colors indicate the strength of the prediction. And these green ones here show the ones that explain most of the variance here. Collectively, the whole analysis explains something like 60%, 67% of the variance in LM observed in this group by that. And if we look at here the top 10, they're all things that relate to this. That's a B cell marker, that's a B cell marker. These are the macrophages in the airway wall and so on like that. So these are the things that are the strongest relationship for predicting the LM. Now, the next step is to look at the gene expression analysis. And this is the work, of course, that Avi Spira has done, which I'll go over quite lightly, and he'll talk about in greater detail this afternoon. So we can look at the gene expression, and to do that, you can show that the relationship of the gene expression to no emphysema here to very more severe emphysema here. And you can see that some genes are upregulated and other genes are downregulated. And altogether, there's 127 gene expression signature associated with emphysematous destruction. And if you look at that, there's genes that increase their expression are enriched for B cell activation and the immune cell signaling pathways, amongst other things, and that the genes that decrease their expression are enriched for TGF-beta and actin organization and integrin signaling pathways. Now, the way that you get that is you used a mixed effect model for gene expression, and I'll spend a few minutes explaining that. This is the model, as you can see here. There's all these terms, but the terms are, this is the log2 expression for the single gene you're interested in. This is the intercept for the assumption that you've made that it's a linear relationship. This is the effect of the different slices we talked about. The B is for the slice. And then this is I and J here is the effect that it has for the individual sample and patient. And then this represents the random error effect for the patient I, for the sample I from patient J. And from that, you can do that. So you then, for the same gene, you write another equation which has all of the same terms, except you introduce a term for LM here, and then the variation in LM and so on like that. So you run both equations, and if one equation predicts the findings better than the other, this equation taking LM, and it passes the false discovery rate and the test for significance that are related to that, you say that gene then is related to the emphysematous destruction. Now, the next point that I want to talk about is that Mark Say, the current graduate student I have working with him, while we were fussing with this sort of thing and trying to really understand what Spira and his group were doing, he said, why don't we put those volume fractions that we've calculated for the cellular infiltrate into this same equation? So that would give us then the gene expression that's associated with the infiltration of the tissue by that cell. And that sounded like a pretty good idea to me. And he did that right away. So this is essentially what we're doing, is we're comparing gene expression associated with LM to the expression associated with cellular infiltration. So here's the LM for the AFI gene expression. Then we do the same thing by putting in that equation the CD4, the CD8, the B cells, the macrophages, the PMN, the eosinophils, and the natural killer cells. And when you do that, the ones that reach this false discovery rate that you want to reach, well, of course, the 127 we've already talked about, the CD4 and CD8s, even though there's lots of genes associated with it, in this completely random, unbiased approach, there's nothing that passes the false discovery rate. When you hit the macrophages, there's 353 genes that pass it. And when you hit the PMNs, there's over 2,000 genes that pass it. So it gets to be sort of complicated. But you can, and again, this was suggested by Mark, is that if we took the top 100 out of this 127 and then took all of the other top 100 genes, we could then ask the question, are any of the genes in the top 100 here also in the top 100 of the LM genes? And if they're there, are they there greater than you'd expect by chance by doing a chi-square analysis on those equations? And what we found was that naturally it's the same 100 here, but we found 12 genes related to CD4 cells that were occurred in this group much more than you could explain by chance. We didn't find any for the CD8. We found 18 for the B cells and 20 here for the macrophages, and effectively none over here. And when you looked at the statistical association here, there was significant statistical associations with the CD4 cells, the B cells, and the macrophages. So we concluded from that the genes expressed that are associated with these three cells, infiltrating cells, corresponds to genes that are expressed in relation to emphysematous destruction, and maybe this relationship is telling us something about what the inflammatory cells are actually doing in that tissue. So if we look at what genes are involved, here is this gene, which is involved in angiogenesis, something that's a very important part of the tissue repair process, and that involved all four of these things, the LM, the macrophages, the CD4, and the B cells. If we looked at another gene with this relationship, and this gene it's important in the response to infection, and again in tissue repair, and again we can sort out the specific cells that are associated with LM, and you get those sorts of relationships. With the B cells here, a gene that's very involved in the B cell expression, B cells rather, marker, you can see it's expressed in B cells and in macrophages. And this one, which is very involved in the hemopoietic cell differentiation, which occurs in this response because the B cells are differentiating and the macrophages are differentiating into many different phenotypes. So that this again could be an important gene, and it's expressed in many of these cells that are associated with tissue destruction. So in summary then, what have we shown here? Well, we're pretty confident about the fact that the destruction of small airways precedes the onset of emphysematous destruction in COPD, and that occurs before COPD can be recognized by radiologists, with the possible exception of when they look at the inspiratory and expiratory scan and see where the gas is trapped. The appearance of the emphysematous destruction in persons with normal lung function may identify those who will be the rapid decliners in COPD. And I say that's a hypothesis. It's not proven yet, but it's a possibility. And that the emphysematous destruction, that is the increasing LM that we've been talking about, is associated specifically with CD4 T cell and B cell and macrophage infiltration, and that the genes are associated with both emphysematous destruction and inflammatory immune cell infiltration may be relevant to the pathogenesis of COPD. In closing, I'd like to thank all of our many collaborators who worked on this work, particularly Joel Cooper, an old friend. I first met Joel when we were residents at the Mass General many, many years ago, and we've kept in contact ever since. He would not have claimed to invent the lung transplant, but he's certainly the person who made it work when he was the head of thoracic surgery at the Toronto General Hospital, and has done wonderful work both at the Washington University in St. Louis, and he's now at the University of Pennsylvania. And he has been the source of the specimens that we've had, and a very valued collaborator over many years. From Boston University, there's Avi Spira and a group of people who have been graduate students with him, Julie Zeskind and Josh Campbell and John Brothers, who all earned their PhD working on various projects that he'll be talking more about this afternoon. Mark Lenberg, who's the statistician who worked with us, and the molecular biologists who do the things. And then the many collaborators that I have in Vancouver, Mark Say, who I've spoken about, and who's a current graduate student, Masaru Suzuki, who's done a lot of the quantitative histology, that is a postdoc who's gone back to Japan. John McDonough, who's done a lot of the early micro-CT work, is now a postdoc in Imperial College in London. Tilly Hackett, a person who I continue to collaborate here with Vancouver, and Dragos Vasilescu, who works with us here, and Daisuke Kanose, who are current postdocs with me. Juan Tan is, and for getting the can cold study going, and I'm able to collaborate with her closely because we often talk about the can cold study much too much in our relationship. Jonathan Leipzig and Cameron Haig, who are the radiologists who did this labor of, I couldn't even call it love, but with Juan's urging, they read all these things. And to Harvey Coxon, who is now doing the quantitative analysis of these things. And then Mark Elliott and Don Sim and Steve Lamb and Peter Parry and many others who I can't add to the list that I've worked with for many years. And of course, the financial support that I've received from the NIH and from the CIHR and the BC Lung, and also from industry, especially from GSK and Boehringer and Merck. So with that, I'll close, and thank you very much.
Thank you very much, Jim, for your lovely talk. If you had $1 million, or maybe $1 billion, which molecule or molecular pathway would you bet on as a druggable target that can modify natural history of COPD?
Well, I'd like to answer that question two ways. First of all, I don't think we can pick the druggable target yet. But I think what could be done, and you know, there are drugs that are off patent now that are well studied, and I'm thinking of things like losartan, the angiotensin receptor blockers, that have a long history of preventing chronic renal disease. Now, it means to me, because chronic renal disease has many similarities to what we've been talking about, in that you have to knock out the nephrons one at a time, and you maintain your function for a very long time till suddenly it goes at the end and you go into renal failure. And clearly losartan is a drug that can prevent that. If you did a clinical trial, or if you did the sort of thing that Dennis does, where you look at people with the early disease that have sort of dynamic hyperinflation, and ask the question whether losartan could reverse that in the early stage, or ask the question, if you treated people not in gold 2 or gold 3, but people, you know, that have abnormalities on their chest x-ray or on their CT scan with normal lung function. If you treated those people long term, you might get a beneficial effect. And I think that would be worth a trial, worth a try as a clinical trial, because it would provide a relatively cheap form of therapy that's been proven in other areas, has been shown in mice to reverse the smoking emphysema in mice. It's published in JCI a few years ago, and would be a benefit. I'd like to see that kind of clinical trial done.
Stefan?
Jim, seeing that you've shown that a lot of the small airways are knocked out before the lung functions are abnormal, that ABV1 can be classically measured, what would your ideas be? What can, if we want to do these trials, obviously we have to identify these patients. How do you think we're going to identify these patients that we can enroll in the trials?
Well, I think we're doing CT scans to detect lung cancer now. It's being much more common. And I think Steve Lamb has pioneered this area here in Vancouver. If we added to that, people who have normal lung function and in our high-risk group cheaper, the CT scans with inspiratory and expiratory things, so you looked at it with that sort of vantage point, and you look for the ones that had early emphysema especially, those would be the people that you'd concentrate on. And I think going forward with the can cold and with COPD gene, we'll learn, I mean, this is a hypothesis at this stage, but it's the experiments to test that hypothesis, in my view, are already in place and running. So we'll get some answers to that. And then I think that the more elegant approach, I mean, we don't want to go back to the small airway test things, but I think that Dennis has very effectively shown, and he'll be talking about it later, that people with this early disease can be detected by, when you stress them, they do dynamically hyperinflate. Like the cardiologists stress their system in order to find early disease, we should be stressing our patients to see whether they develop this dynamic hyperinflation. And so I think there are lots of things that could be tried.
Peter.
Jim, that was a wonderful talk, and you've emphasized the potential importance of macrophages, which fits in with the idea that you see clumps of macrophages around holes in alveoli. But macrophages are very complicated, and probably there are many phenotypes like lymphocytes, but we don't recognize them. I just wonder if your technology allows you to look at individual cell gene expression, because then you could specifically look at the ones that were eating the lung. Yes.
At this point, that's our ultimate goal, is to be able to laser capture individual cells and do individual cell gene expression. And we talk about it a lot, but we're not there yet. But I think that the advantage that we might get out of looking at the genes that are expressed in relation to specific cell types is to see if that expression is enriched for the various genes that are associated with I think it's up to 5 different phenotypes of macrophage. Because as you know better than anyone else, these macrophages can be involved in the inflammation if they're one phenotype. They can be involved in the remodeling if they're another phenotype. They can be involved in the angiogenesis, which is fascinating to me considering that one gene that showed up, and many other things. So I think we might be able to sort that out to some degree, hopefully at the early stages of this thing, and then work towards doing gene expression in laser captured cells.
Great. Any other questions? Ron?
Jim, it's really interesting. I'm wondering, have you thought, or is it would be a way to look at the opposite phenotype patients, the ones that seem to be resistant or immortal, even though they're exposed to risk factors?
Yeah, I think that's a really good question, and I love that thing you can get off the internet that shows this old lady smoking, celebrating her 100th birthday, who's clearly in that group. But it's very hard to get a hold. They don't get sick enough that we ever get our hands on their tissue, So that. But if there have been people to say that to look, and I think this should be explored, is to look at the gene expression in the tissue we look at, and also look at skin fibroblasts or something, and then you could sort of try and do that.
Yes, Tim.
Jim, that was a great talk. Thank you. You raised a tantalizing little morsel there, but flew past it, the microbiome. Can you tell us anything about what you're finding there?
Yeah, yes. First of all, there is a microbiome in the human lung in this thing. It's much smaller, and in a normal lung, equally diverse. We have data, and Mark Say will be presenting this at the student thing tomorrow. We have data that shows it gets less diverse in people who have COPD, and their organisms emerge, that at least families and genus of organisms.
Program directors,
yes.
physician leads, operations leaders, and TST, please report to the bed meeting at 10 a.m.
Now that we've had that important announcement, which happens nearly every time we have one of these conferences,
physician leads, operations,
and we always have to listen to it twice.
Please report to the bed meeting at 10 a.m. on the 3rd floor in the Providence building. Thank you.
So that there is a microbiome there. It looks like there's a response to it, and we're using, the reason we got into looking at all these cellular types and the gene expression is we're using that to measure the host response to that microbiome. And we're just sort of writing up our first paper on this. We believe there is a host response to the microbiome based on our data. But the trouble with the measurement of the microbiome that we've done so far based on the 16S is that, and the very elegant work that is done by Sethi and Murphy and those guys that have shown very definite emergence of new strains to cause exacerbations, is that the sequencing that we've done so far doesn't get us down to the individual species and strain level. So we're handicapped in that way, and we need to do this, very dense next levels of sequencing to get down there, and then we have to do some experiments to see whether the organisms that are there are really alive or not. And there's some really neat ideas out there about how you might go about doing that. But I don't want to take up any more time.
You're like an enthusiastic teenager. Amazing. Any other questions? Yes, in the far.
From your study, then, do you believe that in patients with chronic bronchitis, the initial process is emphysematous changes?
Chronic bronchitis, I think that's one of the great things that Fletcher and Pito showed is that people could have chronic bronchitis, which they thought was the British hypothesis that the cigarette smoke depressed your response, hit toast response. Then you got infection, and the infection produced the chronic bronchitis and the emphysema. But they showed very clearly in their longitudinal studies, prospectively, that you could have chronic bronchitis and nothing ever happened to you. And you could have no chronic bronchitis and you'd develop severe COPD. Now, others have shown that some people with chronic bronchitis have the small airways disease and some people don't. So we suspect it's the people who have the chronic bronchitis with the small airways disease that develop the emphysema. We think that's the starting point for the emphysema. And that's not a new idea. That's what Leopold and Goff thought when they first described central lobular emphysema. They thought it started in the terminal bronchioles. So the problem is in the terminal bronchioles and perhaps the pre-terminal bronchioles initially. And then it spreads into the alveolar surface. Where emphysema looks so important is you can see the emphysema. The pathologists in the early days when they cut the lung, they could see the emphysema. The radiologists can see the emphysema because it gets into their range. They can see things down to about 1 millimeter, so the emphysema gets that size. The terminal bronchioles are all about 400 micrometers. So unless you do something to disturb their function that allows you to look at trapped gas, you can't find that disease. So I think the disease starts in the terminal bronchioles and spreads, and chronic bronchitis can be there or not, has its own set of problems, but it's not the thing that